antibiotic and antifungal block. Speaking of block, so I'm sure you have familiarized yourself with general pharmacology, right?
Yes.
So as you can see from my screen now, general pharmacology encompasses introduction to drug administration. So you have been exposed to mechanisms of actions of drug. Then you have been taught about absorption, distribution, metabolism, and elimination. So you've done a bit of a mathematical calculation. That is normally not very complicated. It is quite simple. It can be easily come out in a OBA question. So to list down some of the attributes of drugs about elimination, and then time course of drug effects. So this is all about what is the definition of agonist, antagonist, what are the behaviors when you look at a graph, and then you can guess the attributes, the characteristics of a drug based on those graphs. So I don't have to explain too much on the agonist side, so we will focus on Adrenoceptor agonist today. So in the second block, you learned a bit about autonomic pharmacology. So the first lecture of this block, it was on direct and indirect cholinergic drug. And then you have been taught about antimuscarinic drug, and then nicotinic receptors, muscarinic receptors, so on and so forth. And then when we talk about adrenoceptor agonists, I will show you a paragraph and flowchart on how we categorize this and where you are. Okay. So here comes our title of lecture, Adrenoceptor. It is not receptor, Adrenoceptor agonists. And the word agonist here normally imply drugs that stimulate along together with a prototypical drug. Learning outcome, you need to identify sympathomimetic agent, that is another name for adrenoceptor agonist. Describe pharmacokinetic profile, pharmacodynamic actions, MOA, clinical uses, and adverse effects. So for this lecture, you can easily come up one question in true false and one question in OBA. So are you familiarized with the format of the exam? So you might be still a bit in the limbo, but you can refer to the study guide. So what is a format in paper 1? What is a format in paper 2? Paper 2 is all MEQ. So it is slightly different than other module. For instance, pathology. We have extended matching items, whereas you can't find this in other modules. Okay? So let the readings initiate from the site. We are still trying to help you to remember what you have learned. So you might not exactly seen this. You might not have exactly seen this subdivision chart, but I might as well go through that just to help you to know where you are. So our human nervous system is subdivided into central nervous system and peripheral nervous system. Up to this point, it is quite clear. For peripheral nervous system, that can be further subdivided into somatic nervous system that controls voluntary actions. When you say voluntary, that normally implies something you can control. Okay, we receive input from the sensory organ, and the outputs are normally for skeletal muscle. Skeletal muscle, for instance, the muscle of your hands, your legs, your body. So the second category is autonomic nervous system, that is normally in charge of involuntary movement. Involuntary means something you have less control or you have no control at all, like heartbeat. So, and then the way you blink your eyes is actually involuntary, although in some time you can control when you want to blink. So the inputs are normally, when I talk about input, it means where the signal is coming from. The signal is coming from internal receptors. You are coughing. The outputs are normally to smooth muscles. So where do you get your smooth muscle? Okay, dry tract. And glands. So glands are normally the one that secrete hormones, and you can't control how much hormones you want to secrete. It normally depends on the signals from receptors in telling you how much you should release. So in autonomic nervous system, something you can't control, pretty much like exam. It can be divided into sympathetic motor system. We have learned about fight or flight in anatomy and physiology responses. So it normally involves neurotransmitter. For instance, noradrenaline, or more specifically, adrenergic system. Whereas parasympathetic motor system, it is more of a relaxing response. The neurotransmitter involves acetylcholine, and for this system, it is called cholinergic system. You've learned that in your previous, the first two lectures of this block. So we're focusing on adrenergic system now. Fight or flight response. I hope you're still not sleepy yet. For the drugs in autonomic nervous system, cholinergic are pretty much covered in the first lecture, like I said. Now we're focusing on sympathetic side of the block. So adrenoceptor agonist is located here, and it is also commonly known as sympathomimetic agent. So it mimics the sympathetic actions. There are three groups here. It is not supposed to be two. So direct action, indirect action, and somewhere in between we call it mixed action. So for the indirect actions, it will displace catecholamine, and then there's another group inhibit catecholamine. We are still trying to revisit. So we are focusing on sympathetic system, and they're mostly in this type of signal transfer from noradrenaline here is equivalent to norepinephrine. They refer to the same thing. So you can see in either smooth muscles or blood vessels, there are a lot of adrenergic receptors. It can be alpha or beta receptors. We'll come to that later on how to categorize them. So it is just a very small part of this slide, but there are a lot of drugs that confuse you. So I hope you can enjoy the ride. Later it's a bit bumpy. So epinephrine is equal to adrenaline, and norepinephrine is equal to noradrenaline, thanks to the British and US English. The receptors involved here are alpha 1, alpha 2, beta 1, 2, and 3. So catecholamines are hormones made by your adrenal glands. Do you know where your adrenal gland is? You heard yes, so I don't have to explain. So sympathomimetic agents are the agents that activate adrenergic receptors. Okay, so those are the two keywords. So for this slide, we will briefly talk about the synthesis and the release of norepinephrine from adrenergic neuron. So the first step involves synthesis of norepinephrine. Second step, uptake into storage vesicles. The third step, release of neurotransmitters. There's an influx of calcium that causes the fusion of vesicles with membrane cells, and the release is blocked by guanidine and brachydium. The fourth step it involves the binding to receptor. Fifth, removal of norepinephrine, and the sixth one is metabolism. That is pretty much outside in the ganglion, and it is supposed to be removed when it is to avoid the excess of accumulation. So norepinephrine is methylated by COMB and oxidized by monoamine oxidase. So it starts from here, synthesis, and then it comes down, combined with the membrane, and then get discharged here, released here, and then when they get released, it will bind to the receptors. So you can't just let them accumulate here all the time. Otherwise, they might exert too much signal. So something needs to be done. So it's called metabolism. They metabolize and then get revert back to the neuron. So that is the concept. So the first 15 minutes is over. Now we focus on adrenergic receptors or adrenoceptor. Okay, it is always adrenoceptor. So in the previous slide I spelled it wrongly, but I feel lazy to change. So I'm expecting you to be smarter to know all these. So we will briefly look at receptors alpha 1 and alpha 2. Those are the GQ receptor. They have weak response to isoproterenol. It is responsive to natural occurring catecholamine. So the examples here are epinephrine and norepinephrine. The rank order for the potency is epinephrine, norepinephrine, isoproterenol. Okay. When alpha 1 is activated, those are the effects. It causes vasoconstriction, mydriasis, contraction and urinary retention, glycolysis, and it will inhibit renin release. That is when alpha 1 receptor is activated. So for the alpha 2, this is the GR receptor. When alpha 2 is activated, it will reduce insulin secretion. It is pretty specific. For beta receptor, it will exhibit a set of responses different from those of alpha receptor. Strong response to isoproterenol with less sensitivity to epinephrine and norepinephrine. So it's an inversion of alpha receptor. For beta receptors, these are the rank order. So beta receptor, there are three types there. Beta 1, 2, and 3. Beta 1 receptors has equal affinities for epinephrine and norepinephrine. Beta 2 has high affinity of epinephrine than for norepinephrine. So what are the effects of beta receptors? So it depends on what type of beta receptors or beta 1. When it is stimulated, it will increase heart rate, contractility, and heavy conduction. I can see that people start yawning. So If you want to yawn, please hide away. Don't let me see it because it is contagious. I might fall asleep. That might be a disaster. So it will increase the renin and increase blood pressure. So that is an effect that happens to kidney. For beta 2, you can cause bronchodilation or vasodilation. It will increase insulin, reduce GI motility, and inhibit labor. So pregnant woman will stop giving birth. Beta 3, you increase lipolysis, relaxation of the bladder. We're going to look at characteristics of adrenergic agonists. So those are the drugs, derivatives of beta-phenylethylamine. It is not very important for exam. It is good to know. There are two important structural features. It depends on hydroxyl substitution, the location, and the numbers, and then the nature of substituent of amino nitrogen. So those are the examples under subdivision of adrenergic agonists. So for direct acting, there are two types: selective and non-selective. For selective one, alpha 1 phenylephrine, alpha 2 clonidine, beta 1 dobutamine, beta 2 terbutaline. Okay. For non-selective, those they're normally affecting more than single receptors. And I want you to focus on ephedrine. So this is a prototypical drug for this lecture. So whatever that mimic ephedrine, they are called sympathomimetic drug. So norepinephrine is also quite important. It is frequently you can see that in exam a lot. Mixed action, ephedrine. So indirect acting. To be honest, for this lecture, indirect acting might not be as important, simply because this drug will be discussed in other lectures. So I'm not asking you to skip. I'm asking you to focus on this part. Just for now. Okay. So catecholamines are sympathomimetic amines that contains. This is a bit lengthy, so I'm going to skip. So they are also called catecholamines. So these compounds share the following property. It has high potency, rapid inactivation, poor penetration to the CNS. Non-catecholamines include phenylephrine, ephedrine, and amphetamine. Amphetamine is one of a drug that is commonly abused. You will learn that in a seminar that comes later about drug abuse. So now we focus on direct acting adrenergic agonists. Do you feel your brain start to spin? You start to confuse, and then you don't know where you are, why you are here. It's a good start for this lecture, for the first bit. So we look at epinephrine. Like I said, this is a prototypical drug, easily come out in a question, and I like to ask question in epinephrine. So it is synthesized from tyrosine in adrenomedulla, and it is normally released along together with a small quantity of norepinephrine into the bloodstream. So adrenomedulla is situated, is located right above. It's like an umbrella, small little umbrella for kidney. So epinephrine interacts with both alpha and beta receptors. At low dose, beta effects like vasodilation, it will happen on the vascular system, whereas at higher dose, alpha like vasoconstriction are the strongest. So those are the example, as you can see from the diagram. So now we look at the actions of epinephrine. For cardiovascular, it will strengthen the contractility of the heart. For respiratory, it can cause powerful bronchodilation, hyperglycemia, because it can exert significant hyperglycemic effects because of increased glycogenolysis. It can cause lipolysis as well. It will initiate lipolysis through its agonist activity on a beta receptor of adipose tissue. So this is the most important part. It can easily be asked. There was one time when it came out in MEQ. So basically, just to ask you what are the therapeutic uses of epinephrine. So once you mentioned bronchospasm, that is a clinical therapeutic use. You just mentioned the medical condition that requires epinephrine prescription. Bronchospasm, glaucoma, anaphylactic shock, cardiac arrest, and anesthetics. You get them up each. So there are 5 marks for this question. You just need to mention this. I want to highlight epinephrine. Have you heard of epinephrine pen? EpiPen.
For allergic
Yeah.
issue.
So that is if you are allergic to certain things, and then you have anaphylactic shock, a very acute allergy reaction. So you actually will have a sudden decrement of blood pressure and start to faint. Normally, that is when you need an EpiPen, and then you will quickly inject into your thigh. That is life-saving. So that is how I help students to remember those medicine and prescription. So for the adverse effects of epinephrine, as important as the therapeutic uses. So it can cause CNS disturbance, hemorrhage that happens normally to the brain and other organs, like internal bleeding, basically, cardiac arrhythmias, and pulmonary edema. So interaction with epinephrine. So it means these are the medical condition, and some of them are drugs. So I would say for interaction, you have to familiarize with certain drug because certain keywords. So when it says what are the clinical use or what are the therapeutic use of epinephrine, the answer is always medical condition. So anyone can explain to me what is a contraindication? What is the meaning of indication? Contraindication? You should learn by now because it is after your general pharm. You should have learned that in general pharmacology. Anyone want to try? Want to raise a hand and answer me what is contraindication? And tell me if I ask something like, what is the contraindication of drug A? So what is the answer should be like? Anyone? So who's in charge of general pharmacology? Then I can have a word with her.
Doctor, can I try? This is from my understanding.
Yeah, go ahead.
But contraindication is when we should not use that medication for this person because of contraindications. Usually, it could be maybe pregnancy or maybe certain diseases.
Okay, that's a good answer. So it can be of any condition. So it can be medical condition or non-medical condition, as long as it is a situation of that patient. So you should mention that in like pregnancy for drug A. So it contraindicates with women with pregnant. So that is the situation. So it can be medical or non-medical condition. Okay. So let's say what is the indication of that drug? It is very close to therapeutic use. So it must be a medical condition. The patient must be sick first in order to get a prescription. Okay. So there was one question last year, and it was about steroid hormone, volume builders that we used it. So it was about TRT, testosterone replacement therapy. A lot of students, we asked about therapeutic use of TRT, other than the men being old, when men reach certain age, they have to start TRT. What are the other indication? So a lot of students answers interaction that has no relation. That is not the answer. You get what I mean? So I think a lot of students confused with certain questions: indication, contraindication, therapeutic use, clinical use. Okay, these four. And then some people confuse with the word adverse effects and contraindication. Yeah. So you have to get ready for those kind of keywords. Okay. So now we focus on norepinephrine. It's neuromediator of adrenergic nerves, and it should be theoretically stimulate all types of adrenergic receptors. So these are the normally in liquid form. So for this slide, we only look at the cardiovascular section of can cause vasoconstriction, baroreceptor reflex, and it will affect atropine pretreatment. There was one question on giving norepinephrine with atropine treatment. So, and you can find the answer briefly here. So, because atropines normally it will block the transmission of vagal effects, and it is normally given before norepinephrine than norepinephrine stimulation of the heart. So those are the way we prescribe it, just to let the drugs that come later to have a maximum effect. So C, we look at isoproterenol. It's a direct acting. It stimulates both beta 1 and beta 2 adrenergic receptors. It is non-selective. On the cardiovascular side, it produces intense stimulation of the heart, increase the rate and force of contraction, so contractility. It can cause increased CO, cardiac output. For the pulmonary, it is as active as epinephrine. It will alleviate the acute arterial asthma. For other effects, it will increase blood sugar, it will increase lipolysis. Okay. Now we look at dopamine. Dopamine, I'm giving you a bit of an assignment here. You can look it up. What are the differences in between neurotransmitter and hormones? And then I want you to go deeper. It is not a very important element in pharmacology, but you'll get really excited to know more about these two things. Some of the neurotransmitters are hormone. Okay, if you go deep enough. So dopamine is one of them. Dopamine is an immediate metabolic precursor of norepinephrine. It occurs naturally in CNS and basal ganglia. It can activate alpha and beta adrenergic receptors. So, have you ever heard of dopamine reward system? So, I'm sure you play a lot of social media. So I don't want to reveal too much of my generation. So you probably are familiar with Facebook.
Okay.
You're still playing it?
No.
No. What are you playing? Instagram. Okay. Yeah, Instagram and. Sorry, what?
TikTok.
TikTok. Okay. So, do you have a sudden urge? Like, for instance, you post something, and then after 1 hour, you keep on reminding yourself you should go back and check, you get how many likes. And then probably in Instagram, would you be able to track who is actually seeing that among your friends? Do you secretly do that? So that is triggered by dopamine. So if you get more likes, if someone you like actually sharing your video, your pictures, you'll get really happy and satisfied. That is a dopamine reward system. So it is a very interesting hormone and neurotransmitter. The actions of dopamine, cardiovascular side, it will stimulate beta-1 receptors at the heart. So you can have inotropic and chronotropic effects. For renal or visceral, dopamine dilates at renal and splenic arterioles by activating dopaminergic receptors. Okay. Dobutamine is synthetic direct-acting catecholamines that agonize beta-1 receptor. It has stimulatory activities. So when you look at neurotransmitters, you should also look at what stimulates and what inhibits. Dobutamine is used to increase cardiac output in congestive heart failure as well as inotropic support after cardiac surgery. Now we focus on oxymetazoline. Don't sleep yet, you'll sleep after my class. So if you couldn't sleep at night, you revise pharmacology, you have to sleep. So oxymetazoline stimulates both alpha-1 and alpha-2. It is used locally in the eye or the nose. And they're normally given in a nasal spray decongestant or ophthalmic drops. Next, phenylephrine. So it can cause vasoconstriction. It will raise both systemic and diastolic blood pressure. Methoxamine will bind to alpha receptors, predominantly alpha-1. It will raise blood pressure by stimulating alpha-1. Clonidine, alpha-2 agonist. It will minimize the symptoms that accompany withdrawal from opiates and benzodiazepine. Opiates, you can learn that in drug abuse and anesthetic. Benzodiazepines, you may learn that in the first lecture of second semester. That is on sedative and hypnotics. But if you're lucky enough, I will give you that lecture. I don't know yet. Metaproterenol. Although it is chemically similar to isoproterenol, it is resistant to cold. Produces dilation of bronchioles and will improve airway function. So it is used to treat asthma. So albuterol is commonly asked in exam. So they are short-acting beta-2 agonists. They are used as bronchodilator, administered by a metered-dose inhaler. So anyone is using inhaler for bronchodilation. It is quite common. So I'm quite sure you have. So there are 105 students here, at least one I would have guessed. So salmeterol and formoterol, beta-2 adrenergic selective, long-acting. So you can see this is short-acting here, and then salmeterol, long-acting. They are agents of choice to treat nocturnal asthma. So that is the asthmatic attack that happens at night in symptomatic patients taking other asthma medications. So because of this nature, long-acting. So they are given on patients that suffers at night. Okay, indirect acting. We still have 20 minutes. The first one we'll look at is amphetamine. This is a marked central stimulatory action. It is commonly abused by users. So this is a CNS stimulant, and it is used to treat hyperactivity in children, narcolepsy, and appetite control. So amphetamine can increase the level of dopamine in the brain. So that is why it is. Have you seen anyone with ADHD?
No, but
No. It can be found in children, but I've seen an adult who has ADHD. She's very active and then keep on talking, non-stop, nothing can stop her. So I feel like very stressed beside her. But then we know the condition, so we can't say much. So it can be quite intense if you are dealing with one as a friend socially. So the next one, amphetamine shouldn't be given to the patient that's pregnant. So in this case, it's contraindication. Theramine, you learn about theramine. There's one cheese syndrome. Theramine is not a clinically useful drug, but it is important because it is found in fermented foods such as cheese and Chianti wine. So this is a wine. If you drink that or you have the cheese, you have a lot of theramine in your body system. So it wouldn't be much of a problem unless you have a problem with you're taking medicine we call MAO inhibitor. So theramine is normally oxidized by MAO, monoamine oxidase, in the GI tract. But if the patient is taking MAO inhibitor, it can precipitate, it can cause a lot of accumulation of theramine in the body. So it can cause serious vasopressor episodes, sudden spike of blood pressure, and it can be life-threatening. So cocaine is something that you probably have heard of even when you're small. Cocaine is unique among local anesthetic in having ability to block sodium potassium activated ATPase. Like amphetamine, it can increase blood pressure by alpha agonist and beta stimulatory effects. So this is how cocaine looks like. Now we look at mixed action. Ephedrine and pseudoephedrine. I like pseudoephedrine personally, but simply because I dislike a runny nose. So it is quite effective to stop your nose blocked and runny nose. So ephedrine and pseudoephedrine are plant alkaloid that are used, that are made synthetically, and it has mixed action adrenergic agent. They're not only released, store norepinephrine from nerve ending, but also stimulate both alpha and beta receptor. Okay, so there's a wide variety of adrenergic actions that ensure that they are similar to those of ephedrine, although less potent. So if you're having cold, probably because of virus, flu, so if you go to pharmacies, what kind of drug you're about to get? For instance, you're having runny nose, then you have pseudoephedrine, and then normally it comes one tablet. So apart from pseudoephedrine, what do you have? And then the pharmacist will probably ask you, do you have headache? So you have fever? So what is the very common, it is very easy drug? Paracetamol. So paracetamol is normally mixed with pseudoephedrine. Yeah. And I haven't seen this in Malaysia. It is probably not recommended by formulary. In other countries, they normally put caffeine in. So caffeine, paracetamol, and pseudoephedrine, these three. So I'm giving you the inspiration. Probably next time when you're about to invent, you can mix caffeine in. Because normally when you have runny nose, you have common cold or flu, you get really sleepy. So you should put a bit of caffeine in just to lighten up the patient's day. So ephedrine and pseudoephedrine, the therapeutic uses. Ephedrine enhances contractility. It will improve motor function in myasthenia gravis. It is used to treat asthma. It can be used as a nasal decongestant For pseudoephedrine, it can be used to treat nasal and sinus congestion or congestion of eustachian tubes. So I probably will play this video